Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the Saudi Society of Pediatric Dentistry. This is Linda Mirza. I'm a pediatric dentistry consultant and one of the board member of the SSPD. I would like to welcome you all to our February webinar. In this webinar, we are hosting two distinguished speakers, Dr. Nitesh Tewari and Prof. Chedid. It's my pleasure to moderate this session tonight, and I really wish that you all have an interesting and useful time. This activity, as I said, it's organized by the SSPD and it's accredited by 2 hours from the Saudi Commission of Health Specialties for the SSPD members. Due to COVID-19 pandemic effects on international flights, the SSPD will take you in a scientific trip from your home or office via the screen of your desktop, laptop, or mobile phone. We will take you direct to India, especially to New Delhi. We will meet Dr. Nitesh Tewari. Dr. Nitesh Tewari is an associate professor in Pedodontic and Preventive Dentistry Center for Dental Education and Research in All India Institute of Medical Science in New Delhi. He is the director of International Association of Dental Traumatology, and he is the joint secretary of Indian Society of Dental Traumatology. Dr. Tewari is also an executive committee member of Craniofacial Research Foundation in India. Good afternoon, good evening, Dr. Tewari. I think it's around 9:30 in India right now.
Yeah, 9:32 to be precise, 34.
Yeah. Good evening, welcome. Shops India, Swagat Hai. It's really a pleasure to have you with us tonight. And thank you so much for accepting our invitation to be with us tonight.
Pleasure, Linda.
Thank you so much. So now let me introduce Dr. Tewari topic. This is a picture of CPCT of dental trauma case. Many pediatric dentists will think that this tooth has poor prognosis, or they think it only can be managed by peri-apical surgery. The majority will refer these patients to oral surgeons or endodontists to perform aggressive approach of management. Dr. Tewari, in his presentation, will highlight the importance of understanding the biology for the development of these peri-apical resorbative lesion due to traumatic dental injury, and he will suggest for us a regenerative non-surgical approach for management. Dr. Tewari, the mic is yours. I really wish for you the best of luck, and I wish for all the audience to have a useful and interesting time.
So is my screen visible?
Yes, it's
Linda,
clear.
Okay. So this is the topic. Thank you, Linda, for your kind introduction, and thanks a lot, Saudi Society of Pediatric Dentistry, for inviting me for this talk. It's actually a pleasure to speak on something related to dental trauma, and it's an honor to be there in your February webinar. Thank you so much. So this is where I am, and this is around 9:30 p.m. in India and around 7 p.m. in Saudi Kingdom of Saudi Arabia. And India is actually a diverse nation, as you all know. It has got different cultures, different faiths, different religions, and different cultures basically. So that's how we recognize India worldwide. And this is the place where I am speaking from. That's New Delhi, or Delhi, as you all know. So this is the capital city of India, and the institute where I work is All India Institute of Medical Sciences, New Delhi. So that's the premier institute of Government of India, and it's under Ministry of Health and Family Welfare. So one of the centers of this premier institute is Center for Dental Education and Research. So it's the center. This is the building where I'm sitting right now, and I'm lecturing from my office. So we are also the Center for Excellence for Implementation of National Oral Health Program. We are also WHO, World Health Organization's collaborating center for oral health promotion, and also an evidence-based medicine partner for Cochrane Global Health. So there are two societies which are very close to my heart, and one of them is Indian Society of Dental Traumatology, so which we founded in 2017. And we are now a small society, a young society, but we already have around 430 live members. And these are the different events. Very recently, we had our virtual conference in October last year, and we plan to have one more this year. Let's see how things go on. Another association for all or everybody who has dealt with dental trauma must recognize is International Association of Dental Traumatology, and I'm proud to be a part of it, and you all should also follow it as far as your interest in dental trauma goes. So that's what Dr. Linda was talking about. So how many of you of the all attendees who are there right now listening to me worldwide, so how many of you will be keen on doing a patient like this on a next day, tomorrow morning, if a patient like this comes to you with a CBCT or an IPA which is like this? And more often than not, you will be thinking in the lines of either the tooth is having a poor prognosis, or you will be thinking of doing an invasive surgery or doing a grafting because you think that your normal endodontic protocol or pediatric endodontic protocol will not be working. So that's what we will be discussing in next 40-45 minutes, and we will be learning and unlearning certain concepts. And mind you, this is not something which is out of the box, or which is something very expensive or unique. Anybody in the world, in any part of in any part of the globe, can practice these principles. These are basic biology which we'll be talking about in next 40-45 minutes. So before we start, there is mixed terminologies to the lesions which cross the apex. So as a dentist, you have understood the dental anatomy, and you know what is crown, what is root, what is apex, what is periodontium. So there are different terminologies. So whether you recognize it as a periapical lesion, you can call it peri-radicular lesion because it extends around the root periphery. You can call it periapical granuloma, like we read in our endodontics textbooks, or you can call it a periapical cyst or a radicular cyst if you can visualize a radiopaque margin of that cyst or that radiolucency. And in AE classification, it put the standard thought process, and we now have a very clear definition of periapical lesions, which are secondary to the pulp infections. And this can happen both in cases of dental caries and trauma, but sadly the dental trauma of the anterior region is quite common, and we often see a delay in reporting of the dental trauma patients to in our society, and then we end up with certain adverse consequences which otherwise the children are not subjected to. So like the classification for AAE goes, it is either the normal periapical tissue or normal apical tissue. We call it symptomatic apical periodontitis if the patient is in pain. We call it asymptomatic apical periodontitis if there is no radiolucency in the apex, but the patient is not having any pain, but there can be a discharge, or there can be some tenderness on percussion. Then there can be an acute apical abscess if there is a pus discharge or a sinus there, or there can be a chronic apical abscess if there is a pus discharge and the patient is actually not complaining of anything. So if you just go back to the etiopathogenesis, because in the course of discussing the treatment modalities, it's very essential to understand how the problem begins. So any of the traumatic force in the tooth of a patient, it happens because of traumatic force which comes from any of the direction. So it can come from labial side, from the palatal side, or from the incisal side, so or in the axial directions. And what it does actually is that we can understand by this diagram, which is continuum of trauma outcomes. So whenever there is an injury, it is going to have a compression of the periodontal ligament fibers, or the connective tissue which is comprised of periodontal ligament, and there can be a destruction of cementum, alveolar bone, and the exposure of the pulp. This is the immediate things which is happening. And then on a microscopic level, you will see that neurovascular bundles, the nerves, the blood vessels, they are severed. The blood supply to the tooth is either detrimented, or it is stopped completely. That's how the things go when the tooth becomes non-vital after trauma. There can be tissue ischemia, there can be crushing injury. So many things are happening. So a mix, or the mix of the results of the healing responses is the peri-radicular lesions, which depends upon the severity and the delay which happens. So if you go into a little deeper into the microscope, and you just understand what are the cells are we dealing with. So we are dealing with different sets of cells in the pulp and in the peri-apex. So if you just concentrate that if the injury occurred onto the tooth and there is an exposure of the pulp, what are the cells which get affected? So they can be odontoblast and its processes, that's the dentine primarily. They can be neurons, they can be blood vessels, the neurovascular bundle like I told. They can be the blood will be there because since the blood vessels are there, they will be rupturing. So you can imagine the trauma happening. So many of the cells are actually involved in the process, which are at the microscopic level, and that their outcome is visible when we are dealing with a patient on a macroscopic level. So then there will be lymphatic vessels which are severed. There will be extracellular fluid, and there will be stem cells which are there in the healing process. So these are the different cellular moieties which are involved in the process. And if you concentrate on the periapex, the more or less the cells remain the same except for a couple of them, which is the periodontal ligament related cells, which is the cementum, the alveolar bone, the osteoblast, and these are the cells which are either trying to heal the body, or they are getting affected in the process of resorption. So that's the basic physiology. And what actually it results, if the impact is so severe that the body cannot cope up with the healing response, it will lead to a arrest of root development like we see in open apex cases. There can be external root resorption like you can see in this radiograph. There can be resorption of the alveolar bone like you can see, which is manifested in the form of the dark color or the relucent area in the radiograph. And there can be development of a granuloma or the cyst, which is an inflammatory response to all these things which are happening. And ultimately, when patient comes to you, they will be coming to you in the form of pain. They can come with complaint of discoloration, mobility, pus discharge, swelling. So these are the main complaints which the patient comes with. And in my OPD, in my OPD in Center for Dental Education and Research, Department of Pediatric and Preventive Dentistry, so we see a great amount of delay when the patient is coming to you. So the greater is the delay, the greater is the chance that these complaints will arise. There will be resorption, and there will be some sort of a peri-radicular response, which we usually don't expect in the Western countries, and we are not really bothered about it because that is quite rare. So how do you diagnose it? So once the patient has reached to your OPD, and you know that the patient is in pain, and there can be a history of trauma. If it's anterior regions, definitely a history of trauma. So you can directly ask if a patient is coming with a swelling of the lip, or with a broken incisor. You can ask about the history of the trauma. And even though the trauma is an old one, you please record what is the time period which has elapsed, because that will be a part of your dental trauma registry, and that will help you understand how these lesions develop. And then second part will be the inadequate treatment, because many a times you as a specialist, you will be getting a retreatment cases, referral cases of the children. So when you get those referral cases of children and adolescents, then you will be having some history of inadequate treatment. Some of the children do not cooperate with the general dentist, and then if they do not cooperate and the treatment is unfinished, then they end up with some peri-radicular response, and that's what you will be dealing with. So your recording of that treatment modality or the dental history is also important. Then there can be pain. So characteristics of the pain like the radiation severity and any of the relieving or aggravating factors will be important for you to know. Your presence or absence of the abscess or any history of the abscess in past in the same region is also important. Sometimes patients do not tell you on the first instance, so you need to dig a little deeper when you are taking the history. So in terms of clinical examination, you need to perform the regular clinical examination of inspection, palpation, and percussion. You need to see the extraoral tissues if there is any swelling or any deformity or any deviation in the upper lip, in the philtrum, or in any of the region or the malar region where you expect the swelling to be. Then there can be some mucosal swelling intraorally. There can be apulus. There can be some sinus discharge that has to be noted down. So a key to that is that you need to retract the lip as much as possible. Do not rely only on what you see in the interdental region, because the roots are deep, and when they are deep, they will be having some sinuses right there in the vestibule. So you need to retract the soft tissues so that you can really visualize or rule out any sinus or any abscess. So they can be change in color, so that can be a complaint of the patient, or that is something which you notice. There can be mobility of the teeth, which resolves as soon as you have a protocol running for healing of the peri-radicular tissues. There are investigations, definitely, because you have to look into what is underneath the clinical crown. So you need to take an IOPA, that's a standard of the care in most of the lesions. And if you have a clear indication for a CBCT, which is quite important and quite helpful in the cases when you have a suspected peri-radicular lesion, so then CBCT helps. And in all the cases, you need to perform the pulp sensibility testing, because you need to know whether the tooth which is involved or tooth which is having pain is a vital and non-vital, and what is the status of the adjacent teeth and the teeth in the other arch. So if your central incisor on the right side is having an abscess, that does not mean that the lateral incisor on the right side or the central incisor on the left side is also non-vital. So your treatment planning depends not only on your history, clinical evaluation, or investigation, just radiographs. You need to work on the sensibility test, and you need to formulate the entire diagnosis on the basis of whatever information we have. We will be discussing on these points. So what do you see in a radiograph? So in this radiograph, like you can say, and there can be an open apex case like this, when the trauma has led to arrest of root formation, or there can be a closed apex. So you need to see the alveolar bone proper. You need to see the white line which is around the periphery. You need to understand what is the difference in the length of a normal tooth and the tooth which has been affected because of the dental trauma or its adverse consequence. Then the next thing which you need to see in cases of where there is an open apex is the width or of the apex. There's a classification for that, and that's not part of this lecture, but you should evaluate in terms of the SWEX classification for the open apex, because that's how the treatment is defined. You also can evaluate the width of the lesion, that you can evaluate the width of the cementum, because that's also quite important. So then in terms of objectivity of the radiograph, it dates back to 1960s and 70s. So in 1960s and 70s, we were able to do the radiographs, and we were able to see the things which are there, like a black thing and at the apex, or the peri-radicular pathologies. So then the system or the concept of the grid lines on the radiographs was developed. So that grid lines helped an individual to form a diagnosis, or to form the objective diagnosis of what is the exact measurement of the lesion on the two-dimensional radiograph. So a system of a peri-apical index, or the system of objectivity in grading the peri-apical lesion was also developed, and that was developed in 1967 and improved in 1980s, where they formulated a PAI index. So that's something like this: the PAI grade 1, PA grade 2, grade 3. And if I go have a better picture, it's like that. PAI 1 means the normal peri-apical bone, in which like we have all the normal tissues. If you see a radiograph and there is no black thing, or the no radiolucency in the apex, that means that's PAI1. And then in PAI2, there is a small changes there can be some breakage along with the disruption of lamina dura. There can be PAI3 and PAI4 and PAI5, definitely on the basis of the severity. So in 2008, since the three-dimensional imaging was started, so that three-dimensional imaging led to another scale which was given by Estrella et al. That's quite good article, and you should all read it if you are into research or if you are into academics also. So the just to cut the thing short, so the classification went like 0, 1, 2, 3, 4, and 5, and they had added E and D depending upon whether the lesion had led to an expansion clinically or destruction of the bone clinically. So that's an example. So 0 meant that there was no radiolucency. So a normal tooth means 0. PAI 0. So then on a tooth which with 0.5 millimeter to 1 millimeter, it with like a slight relucency, you can see PAI 1. And the PAI 2 meant greater than 1 and less than 2, or 1 to 2 millimeter. That's the PAI 2 measurements. You can do exact measurements using softwares on a CBCT. And if you are just doing your diagnosis using your radiographs, then also you can have a similar index. But you need to note it down. So do not just mention that the peri-apical radiolucency present in cases of the central incisor with trauma. Always mention an objective diagnosis that it's PAI 1, 2, 3, and similarly 5. So in case there is a destruction or just an expansion of the cortex, it's PAI 5 or PI4 with E. We will be seeing that in my cases. Or if there is a destruction of the alveolar cortex, then it can be D. So PAI5D, PAI4D. So E and D also can go together if expansion and destruction are happening all the time. So that's about the objective measurements. So just a trivia for you, because many a times as a dentist, the moment we see a radiolucent area with the central incisors, we are quite excited that it can be a cyst, because that's what we are trained to diagnose. But in this case, if you closely see that, you will find an intact lamina dura. So lamina dura, if you just follow my cursor, it is going like this. It's intact. There is no breach in the apical region. There is no breach. And then the third thing which we're seeing is that there is no apical widening. So a radiograph like this, along with your pulp sensibility test, which shows a normal response in the tooth which is affected or the teeth which are in the vicinity, and no history of trauma, that would mean that it is not related to dental trauma. And that can be something which can be a solitary bone cyst. Like this case of mine, it ended up with a solitary bone cyst because aspiration gave the results like that, and then it had to be operated. So those are the cases which we need to be careful about. So not all cases of peri-apical radiolucency or peri-radicular radiolucency are because of dental trauma. So then that has to be ruled out. And there are very good case reports in endodontics journals. One of them where they found out that the central giant cell granuloma actually mimicked the peri-apical lesion, and one of them, very recent one, where the non-Hodgkin's lymphoma, you can see the amount of destruction. So anybody can relate it with a peri-radicular or a periodontal lesion, but it was actually a non-Hodgkin's lymphoma. So you should keep your diagnosis very precise, and you should rely on all the information which is available to you, rather than just thinking of one or two things. And sadly, in pediatric endodontics and endodontics by and large, sensibility testing is quite ambiguous, and that really needs quite a lot of research in the future also, because the clinicians worldwide need to have some objective methods. And especially when we are dealing as a pediatric dentist, we are dealing with children with injuries or pulpal issues, and then the responses are not reliable. So we need to have some very good objective test. As of now, we have thermal pulp testing. Endo eyes is available. That's quite a good method, and we use that in our clinics. And then there can be electric pulp testing or pulse oximetry, but we need to work on sensibility testing. So right now when you have taken a history, you have done an examination, you have done all the diagnostic tests, so you are sure of the diagnosis. And if your diagnosis is that the tooth is non-vital, and tooth is having a trauma, and tooth is having a peri-radicular lesion, you have got three treatment modalities which are there. So first one which was the contemporary ones, or the something a part of history now, because it's unethical, was extraction. So there were times where the lesions of the peri-apex, they were dealt only with extraction. And some parts of the world still have that philosophy that they can extract the tooth with a large cyst in the apex, which can be treated non-surgically or even surgically. So that's not a good method. That's unethical and should not be done. Peri-apical surgery, yes, peri-apical surgery needs to be done in certain cases, and it is an invasive method, but it's not unethical. It is practice, and it's a standard of the care in the cases where your non surgical methods or regenerative methods fail. But from my experience and from what the evidence tells us in the literature, non-surgical endodontic management protocols are equally efficacious, and they are giving us successful results, and that's what we will be seeing in the in next few slides of mine. So just to summarize how we approach a case of a non-surgical regenerative management of a non-vital traumatic permanent teeth. So if you all just look into the keywords of this title, it is regenerative management. So I'm trying to focus on something where body is trying to heal itself, and then I'm trying to focus on the problem of non-vitality, because the tooth has undergone a pulp necrosis. There can be some or a major periodontal destruction, and the source of the periodontal destruction is related to trauma. So these are the three keywords, and I will be talking about the permanent teeth or the young permanent teeth from the age group of 8 till 13 or 14 years. So first and foremost is the diagnosis and grading, which we have all discussed till now, and then second is isolation and pain control. So in dentistry, if you have a necrosed pulp, there is a general consensus that we do not require to do a local anesthesia, or we do not require to perform local anesthesia for these patients. But in cases where you are dealing with periapical or symptomatic periodontitis or symptomatic periapical lesions, in those cases the patient is having severe pain, and you need to perform local anesthesia, because unless and until you do that, your patient will jump from your dental chair. They will be quite uncooperative and apprehensive. So it's better to perform local anesthesia than not doing it. Then establishing the drainage. So like in all surgeries, you are also a dental surgeon, and ultimately you need to establish a drainage, and you need to perform a debridement. The tools for debridement are the regular endodontics tool, which we have our files, our broaches, and that's need to be done. And then there is an irrigation protocol. So there are tissues, because the dental the pulp canal, or the pulp chamber and the root canal and the periapex, they are quite inaccessible to the regular endodontic the instruments many times, and then you require an irrigation protocol, which is quite standardized these days. You need to perform root canal disinfections. For that you might require some intracanal medicaments, which can be triple antibiotic paste or calcium hydroxides. And ultimately what you are aiming to do, you are aiming to have a disinfected root canal, that the source of infection is gone now, and you need to reverse the process which was happening. So if you remember in the initial slides when I was discussing etiopathogenesis, so I was talking about the cells which are there. The cells in the periapex, they are primarily the osteoblast, the cementoblast, and the periodontal ligament fibroblast, along with the vascular bundles. So once these cells are getting affected, their clastogenesis starts. So they are getting eaten away by the body. And when this is happening, actually the pH is acidic. And in order to reverse that, we need to do something so that the pH gets reversed from a acidic medium to a basic medium. That's the basic physiology of the healing of the bone. So that's what we need to do, and that's not a rocket science, and you do not require very expensive things for doing such thing. And predominantly what we lack in many of our clinical practices is the follow-up. So we might have an excuse that the patient did not follow up because of COVID-19, or patient could not follow up because of other reasons, because they relocated. But if you engage them, they will be coming to you, and unless and until they come to you, will not be able to see the results which you are hoping, because you will not be able to evaluate the success of your treatment. So these things we'll be revisiting as we go. So the first case which I want to discuss here is just a second. Okay, the first case I want to discuss here is a 13-year-old male. He reported with a chief complaint of a pain in upper front traumatized tooth, and there was a history of trauma due to fall from a bicycle 8 months ago. So the trauma happened 8 months ago, and the lesion started developing. So we took a radiograph, we took the history, and in the radiograph we could assess that it was a PAI-3. So we had already discussed with you all what's the PAI scores. So first case, the PAI-3. So that was 2nd September 2020, after the lockdown was over. So we put in the calcium hydroxide. We had done that in the first sitting itself. We have closed the tooth, and then we have recalled the patient after 1 month. So patient could not report after 1 month because of other reasons, but they came back. They came back without any symptom, and they came back in December. And as and when we did the radiograph after 3 months, as per our protocol, we could see that there was some healing which was happening, and that's quite encouraging. And then the further we did the obturation, the normal gattaparka obturation we performed, and a composite. And the last follow-up which we could elicit was on 14th, and there was a substantial reduction in the PAI score, a substantial reduction in the healing. So that's the simplest spectrum. That's the simplest thing which we can do in pediatric endodontics. We can perform in the access opening. We can do the drainage. We can remove the debris which is from the canal. We can do the irrigation, and then we leave intracanal medicament like calcium hydroxide for some time, which is 2 weeks to 4 weeks, or even a longer period, which we sometimes do here, and then we do an obturation. So that's it. That's as simple as that. And these are all straight canals, so that they are not as complex as we find in posterior region. So it's a simple job. Similarly, another patient of mine, which is 12-year-old female, she reported with a chief complaint of forwardly placed upper front teeth. So the chief complaint was not related to dental trauma. Although we could see that there was a fracture of the central incisor, but the chief complaint was the proclination, and the patient was asymptomatic, so there was no pain. So there was no pain, but there was a history of trauma, because we could see that the fracture was already there. And in the radiograph, it was a PAI5, the peri-apical lesion was present there. So what we did the access opening, and we placed in triple antibiotic paste. And after triple antibiotic paste, we placed in the calcium hydroxide again. And then after the next follow-up on December 8th, we could see some condensation. And this time we decided on placing in MTA, and we did a canal obturation using an MTA, because the patient had to undergo an orthodontic treatment, and we were thinking of putting a stable medium there. So as a choice of a medicament, as a choice for a reversal of a pH, we used MTA here. You can see there the lesion decreased, and in the most recent follow-up, you can see the patient's lesion has decreased to PI score 1. So you can easily compare the lesion size in the PA5 in the initial reporting, and then it could reduce to PI1. The patient is yet to report to me, and as and when she does, we will be taking a further follow-up radiograph, and I hope that we can start with an orthodontic treatment, because it has been around 3 years that the patient had initially been treated. So we expect it to have a good bone for orthodontic tooth movement. So one of the cases we'll be discussing today, so that actually quite has got a good spectrum of an interdisciplinary management, and we'll be seeing that in some slides. So this case, MG, 9-year-old male, reported with pain and swelling. That's a symptomatic case in swelling in upper front teeth, which was injured while playing cricket 2 years ago. So the injury had happened at the age of 7 years, and the patient is coming to us at the age of 9 years. And when we did the evaluation, since there was the visible swelling, there was we diagnosed it as a PAI4E. So that PAI4E, you can easily visualize in this slide, that was radiolucency, which was extending into the peri-radicular region. We did the access opening, we placed in MTA, and in few months, you can see that within less than a year, so you can see that the PAI score has gone to 0. So the PAI4E, the lesion like this, if you can be perturbed that what is exactly the prognosis, but just put some thought on diagnosis, put some thought on irrigation, and we actually end up with a good bone healing like this. And these are all real cases, MG, 9-year-old male with PAI score 9, PAI score 0, right around 10 months of the treatment. So that's another case in which the patient had reported at 9-year-old at the age of 9 years, and again the pain and swelling was there in the fractured upper front tooth. You can easily see the fracture lines there in the radiograph, and there was a history of trauma due to sports. So sports activities in the parks and in the schools, they are a cause of trauma in this part of the world, and most of the parts. And we should also try to increase the awareness, so these children can report to a dentist earlier. So if they report to the dentist earlier that these things like pain and swelling can be managed quite easily, and we are working on that as a part of Indian Society of Dental Traumatology. So in the next course, what we did, we decided to do a revascularization because it was an open apex case with a wide apical diameter. So we did a revascularization in our follow-up. We could appreciate that within 2 months there was a decrease in the PI score. There was apical condensation. So whenever you are having a radiograph to diagnose, you should try to magnify the apical region. So in your follow-ups, if you are able to magnify, you will be seeing some radio opacities growing in. So it's quite encouraging for a pediatric dentist, because then we can see that the body is trying to heal, and if body is trying to heal, then half of your work is done. So that's the follow-up. We are not seeing the root growth as of now, but as a part of as a patient related outcome, and as a clinician outcome, we are seeing bone healing. So that was a regenerative case for management of the peri-apical lesions. So Zainab lives in Srinagar. She was referred to us. She was referred to us because she had an injury in when she was trying to skate, and she hit the chin. So usually in our literature in dental traumatology, we find that most of the injuries happen in the maxillary anterior region. But in our cohort, in our center, we have around 10 to 20% of the children which got injured in the chin and then later developed peri-apical lesions, which were misdiagnosed many times. And then she developed pain and swelling after 2 years of trauma. That means trauma had occurred at 10 years of age, and she reported to us. And Srinagar is quite far from this place, but she was referred to our center for management. And this was the radiograph, as you can see on the screen. So that radiograph is PAI 5. That's greater than 8 millimeters or greater than 1 centimeter from either side. So since we did not do CBCT, so that's the PA5, the marking. So the regular endodontics protocol, we did the access opening, the working line determination, and then this is the placement of the metapex there. You can see that the metapex is going inside, and this has to be done after you have established the drainage. So if you have established the drainage and then you have debrided it, you have done your irrigation using your hypochlorite followed by a saline, because saline alone does not affect a lot of debridement. So chemomechanical preparation has to be done, and since you are not doing revascularization or regenerative endodontics here, you have to be slightly aggressive when it comes to debridement. And then you have now you can see the dates 2/11/2019. That's PI5. That's PI5 again in the follow-up after a month. We had called her, and but we can appreciate some bone growing. If you follow my cursor, you can see some bone growing right here. And the most encouraging thing happened right before the lockdown in India. So that was 22nd Feb 2020. We could see that it has gone down from PA5E to PI2. So that's the amount of the bone healing which had occurred. And we have not done quite an expensive or invasive treatment. We have just opened and placed Metapex. That's the calcium hydroxide and iodoform paste. So the patient had undergone a radiograph there in her native place, because they could not travel to my center. And then when they came here on 22nd February 2021, this is the amount of healing which I could appreciate. So that's you can compare from 2019 2nd November to 22nd Feb 2021, regeneration of the bone. It's quite fast, and contrary to what we see in textbooks, that the radiolucency will not be going in 3 months or 4 months. We have cases where radiolucencies have gone within a month or within 2 months. We'll see that. So then second case, it's quite a typical case of tooth reimplantation, because this child had a fight in the school and there was an avulsion. There was a dry storage for 4 hours, and the tooth was reimplanted, and the dentist did everything right. The tooth was this tooth and this tooth, they were managed. This was a subluxated one, and this was reimplanted one, which is right now dark. So they reported with pain and mobility of this tooth, and you can see that there is some sinus opening there. So when we took the radiograph, you can appreciate that there was a substantial resorption, external root resorption. So the body is trying to eat away the tooth. So when there is no root, the gutta perca, which was originally inside the root canal, it was now inside the bone. So we had either an option of doing a surgery and doing an apicectomy, cutting through the bone and removing the gutta perca, because the gutta perca can be a source of foreign body inflammation. So we tried to be conservative, like we always do. We used an H file. We used an H file of 25 number, and that instrument could help us in retrieving the entire gutta perca out of the bone. So you have to be very careful. You cannot jump on a diagnosis of or jump on a treatment plan which is very invasive. You should always start with something which is less invasive and move on progressively in case you fail. So here the key lies in approximating the gutta perca to your instrument, and as close you can go there, and as close you can be fitting between the root canal wall, the dentinal wall, and the gutta perca. Your instrument or retrieval or your gutta perca retrieval is quite easy. It's not the same as we have for instrument retrievals in endodontics, but this definitely works. So then we took a radiograph to confirm that everything is fine. We could appreciate there is some sort of apical radiolucency, which is PI1, and then we took a working length and we placed in calcium hydroxide, because we wanted to be sure that there is no further external root resorption. So in all the cases where you identify external root resorption, always resort to a calcium hydroxide or a suitable intracanal medicament, and do your normal obturation only when you are sure that there will be no further resorption. And then we did an MTA root canal obturation, the through and through MTA obturation, and we could appreciate that in the follow-up there was no radiolucency which could be appreciated. So that's the follow-up. After a year, we can see that there is no radiolucency, and if you compare from what we originally started with, that was 3rd January 2020, and this was a follow-up on 11th of Feb 2021, and in 13 months you can see that there has been substantial regeneration. The quality of the bone has improved, and the tooth is no longer symptomatic or mobile. So this child is had a problem, and we have come across that the most of the cases of long-standing periapical lesions or long-standing trauma, they all end up with with discolorations. So we need to work on some strategies for improving the bleaching methods, or improving the shades of these teeth, and so that we can save these teeth without giving a crown. So that's what we did. We tried to bleach the tooth and we could match the shade. Sadly, this tooth, which was unaffected, which was not done by us, that has undergone a pulp canal obliteration, and we can see a yellowish hue coming out. So the child is as of now 13 years. So we still await few more years before we can give a veneer, and the child can have an aesthetic smile. Another case, this is Roshan, 12 years, male. He reported with pain and swelling in the upper front region of the jaw. And the history goes like that: the tooth had injured, the patient had gone to the dentist immediately, and the dentist had advised an endodontic treatment. So everything was fine till 3 months ago, when the pain when the tooth started to give him some trouble in terms of pain, and the swelling started 3 days ago. So when we did the radiograph, the endodontic treatment, you can appreciate, was done in 2018. So that's how long the dental trauma cases can show negative results. So you need to follow your cases of dental trauma. So on 25th March 2019, we can see a radiolucency as big as this, the PAI5E. And then we did the same protocol. Metapex, Aquapex was used, which is an aqueous calcium hydroxide. It was placed inside it is PAI5, immediate post-operative. This is 7th November 2019. So you can appreciate that within a span of 8 months, we can have a complete resolution of a radiolucency as big as these. And these are real dates. These are real patients. And if we can do it here, you can do it in your clinics. So you do not need to go full blown into your invasive methodologies. You can resort to your regenerative protocols, and that's the obturation. And that's how we finished this case. So another case, this was a peculiar one, because it was again misdiagnosed, because the general dentist had done the splinting, and they had advised that the patient requires to undergo a surgery and grafting. There was no advice to perform an endodontic treatment till now, and the splinting and visits to the dentist were at least 3 or 4. So the patient had gone there with the chief complaint of swelling and mobility, and the tooth was not opened yet. Even the history of trauma was not taken. So when the level of awareness also needs to be improved in terms of general practitioners and the people who we are working with, and even for the pediatric dentists, we need to improve the understanding of the trauma pathophysiologies and how the prognosis varies. So when we took the radiograph, you can easily appreciate that there is destruction of the bone all around these two teeth. And that's also quite interesting. I will come to it later on. And we could appreciate that central incisors are both lying loose. There is no bone in the center. And in the OPG also we can see that the same thing. And the date was that was January 2020. The patient's previous dentist had asked for a CBCT, and in CBCT there's a destruction which can be appreciated in all the planes, and destruction of the cortical bone was there. We opened the tooth within the splinting period because the tooth was mobile, so we did not want to do it. We did not want to remove the splint as of now. We did pulp sensibility testing. This was vital, and this was vital too. So then we did the root canal or the opening, access opening, only for the central incisor, which showed negative response to the pulp sensibility testing. And we placed in calcium hydroxide aquapex, and then we placed in some excess quantity. We wanted to have a disinfection, and we wanted to reverse the lesion. And just look at the dates. Look at the dates: 27 January 2020 and 28 Feb 2020. That's just 1 month. And that just 1 month, real time 1 month, and you can appreciate the amount of bone which has grown in. And that's the beauty of regeneration, because body is trying to heal. The lesion has jumped from PI 5D to PI 2, and then in the subsequent follow-ups in 5th October 2020, PI score has gone to 0. So this X-ray simply tells that nothing has happened. And then we further followed the patient on in January 2021. And if you compare it from where we started 1 year ago, so within a year or within a span of 9 months, we were able to grow the bone back. So that's quite encouraging to a dentist and quite encouraging for a young patients. So that's a Prachi, 13-year-old female. She had avulsed 2-1. That's a 2-1, which was avulsed, and she had reimplanted herself. And because she was afraid that her parents will be angry with what she had done to herself, she did not tell to anybody. And then when she reported to us, it was 5 years already gone into the trauma, and there was an abscess lying here. That was 22nd March 2017. That's the occlusal radiograph, and you can appreciate a dentinal bridge sort of formation, because when I first saw, I thought that the dentist has attempted metapex related apexification, but then there was an apexification which body was trying to heal itself, and there was a large periapical radiolucency. So there was a strict thought that we should refer the patient for microendodontic surgery, or we should do it ourselves. But then we thought of doing a non-surgical treatment. That's the CBCT. You can appreciate that amount of bone loss, the cortical bone loss here. You can see on all the planes that the bone was deficient. So we did the access opening, we did the drainage, we established the drainage. That's PI 5D on 2017 March. That's April PI 5. Nothing has changed, but the swelling has reduced. There was no pain. Then we placed in a Metapex for some time. The triple antibiotic paste was placed here for 2 weeks, and then we obturated the canal after 2 weeks with MTA, because we were sure that either the treatment will be non-successful, then we'll be going for a surgery, or we will be successful only by reversing the pH. So that's what we did. The PI score reduced in July to PI 4, then it further reduced within a year, and then that was the occlusal radiograph on 2017 March, and that's 2018 March. And if you just, I will just take you back to this radiograph, this one, and you see it here. There's no lesion there. You can appreciate in the vicinity, which was all hollow. So then the patient had a proclination and some rotations in the incisors, and they wanted to do and undergo an orthodontic treatment. So we did a CBCT after a 1 year and 4 months. That's 18th August 2018, and the lesion, which was all destructive of the cortical bone, it has all healed. So that's 1 year 4 months of CBCT. And then a PI score 5D. That was 5D on the initial presentation, and that's the PI score 0. So that's how body heals. And if you just follow some principles of pediatric endodontics, you will be able to do it. So that's a lesion healing you can appreciate. So then patient is started with her orthodontic treatment in May 2019, and our department of orthodontics in Center for Dental Education and Research did this work, and they have beautiful documentation of their cases. So that's what I am taking from. So that these are the 3D printed and the 3D image scan models. So then you can appreciate the rotations, and then she underwent the fixed orthodontics, and these are the changes over the time period, the September 2019, 7th December 2019, 2020, and that's the healing you can appreciate. That's the healing. So that's the last follow-up which we had on 19th of March 2020. She underwent debonding of the tooth of the teeth, and then that's 28th December 2020. Everything is fine endodontically and orthodontically and as per pediatric dentistry. So that's the beauty of regeneration which we thought. And last case before we move on, it's a horror story, because the patient had been brought to us for an opinion, because the originally the oral and maxillofacial surgeon had suggested that the patient is having an odontogenic cyst, and that there was an expensile swelling in the anterior front region, and there was a fractured incisor. Everything had been done. The operating dentist, they had taken an FNAC, the fine needle aspiration cytology. They had taken a bone biopsy, and they had put the sutures there, but they had not opened the tooth. They had not started the drainage by traditional endodontic measures. And endodontics is a science. It's not just that you can just rely on other measures and you do not open the tooth. You have to open. So then they did not do it. So that was the status, and you can appreciate that in this this occlusal radiographs, the PI 5D and this RVG, and then this OPG which was already with the patient, so we did not repeat it. So that's the image of the expansion which you can see. Even in the CBCT, you can see that the entire bone is gone. And I was quite amazed, because this was a CBCT which was taken after the bone biopsy. So either it is an hydrogenically created defect, or it was an original defect. But still, we thought of, because we had Prachi's case, we had such a substantial healing in a big lesion. So we thought of doing a non-surgical endodontic measures. We convinced the parents, and we asked them for a good follow-up, and then they agreed. And then surgery is always a resort. If in case it doesn't heal, then you can always go back to the surgery. But then, and if you go back to the amount of the bone destruction, even the best of the surgeons will not be able to recreate the entire the tissue which has been damaged. So that's the 11th of November 2019. That's 2nd November 2019. And then that's the original radiograph, occlusal radiograph. And then in the follow-up after placement of the Aquapex, the calcium hydroxide, aqueous medium calcium hydroxide which we used, you can appreciate the amount of bone which is formed. Just follow my cursor. Just follow my cursor around the root apex, and you will be seeing that the good quality bone is formed. It's still healing. It's not that we can work magic in 3 months or 4 months. Body needs time, and we need to have some faith. So that's what we did. So you can appreciate the displacement which was already there. It has reduced substantially. And that's the 5th July 2020. They could manage to come here even in the lockdown. And then when we took the radiograph, there was good amount of bone around the apex. We did the obturation, and when we did the obturation, you can appreciate the clinical photographs. There's a recent follow-up, 2nd January 2021. And when we compare it with 11 November 2019, that's a span of around 1 year and 2 months. So that's how the things changed for this child, PI 5D to PI 1. If we just consider the radiolucency around the apex, still some things need to be done for him, but then we are on the right track. That's what we feel. So what's the evidence like? So I still have 5 minutes. I will be quickly looking into the evidence and then moving on to the questions. So the evidence as per the Cochrane review which was done regarding the periapical lesions and primarily retreatment treatment of the primary peri-apical lesions, it said that there is no consensus regarding the supremacy of the treatment, but supremacy of whether the surgical approach is good or whether the conservative approach is good. But this review had been done in 2012, and there are some good papers which support non-surgical endodontics, but there still needs to be some work which needs to be done in terms of the quality, because overall we do not have a very good quality randomized clinical trials which support either of the therapy. So in my experience, in what I have told you in my and or shown my cases, so I have been having an encouraging results with biggest of the lesions using the non surgical approach. But there will be some people who will be against this method. So we need to do some good quality researches so that we can have a consensus. And one primary aspect of all endodontic treatment protocols is irrigation. So that's again a review which I could come across. That's for the irrigation in the mature permanent teeth irrigation protocol for non-surgical root canal treatments, and that they also conclude that even though doing it only with the saline is not a good policy, you should always have always have an irrigant like sodium hypochlorite, which is antibacterial and which can dissolve the tissues, or you can have other irrigants like chlorhexidine and other things. Even American Association of Endodontists in 2017, they came across one consensus document in which they had graded different types of irrigants, and they had a suggestion that in all the cases you should use sodium hypochlorite 5.25%, and that's quite effective in removing the tissue. So as far as outcome variables goes or the prognostic variables goes, like we are lucky as a pediatric dentist because children have good healing potentials. So we can see that in my cases, and you will also see that in yours when you will be doing them in your child patients or adolescents with trauma sequelae. So then in this paper they had said that even in peri-apical surgery or and in the healing of the peri-apical lesion, there can be tooth related factors which is less than the size of the lesion. If it is smaller, there's a better chance. If the cyst has not formed, it's a better chance. But in most of the cases, you need to focus on age and the type of the tooth and the lesions or your diagnosis which you are dealing with, and finally the treatment modalities which had been attempted. So finally, as I end, there are certain critical highlights which and the lessons learned which we have learned in past 5 years before when we started our pediatric endodontics non-surgical cases. So first is diagnose the lesions on backdrop of all the available information, and always try to objectivize the records. As a pediatric dentist, we do not have a training on objectivizing the radiographs, but you all should do it. And because our endodontic colleagues are far superior in terms of objectivity of the radiographs and the lesions, we can learn from them. And when we do our pediatric endodontic cases, we will be able to appreciate how exactly the success has been achieved, and that's quite phenomenal when you start doing it. It's quite good. And then select your cases well. So you can select your cases surgical, non-surgical, but always have a regenerative approach in your practice. Focus on the peri-radicular lesions, but address the chief complaint. So if the patient has come with a chief complaint of proclined anterior teeth, you cannot just focus on you doing your endodontics or doing your surgery or doing your non-surgical endodontic management. Ultimately, you should be aiming at what the patient has come to you for. And then there is patient symptoms. They reduced as soon as the lesion is drained from the tooth, because if you start your access opening, the patient will be asymptomatic. So then you are the one who is relieving the pain. So if you are relieving the pain, you can take that movement and you can engage that patient for your good follow-up. So that use that exercise, try to empathize with the patient because they have come to you with pain. And then you understand the pathophysiology. That's the biggest of the critical highlights or the lessons which I can tell you. Understand the pathophysiology because you are ultimately a doctor and you are ultimately dealing with the human beings. So understand how the disease is developing so that you can improve on your methods and you can reduce the inflammation. And when you are doing your treatment plan, you are having a view of what exactly are you trying to do in the end. And finally, ensure disinfection and reversal of the pH. You use your intracanal medicament, you use calcium hydroxide, you use MTA, whatever you want to use, you use it. whatever you are confident, because there is no consensus related evidence as of now. Nobody is telling you what to use, what not to use. You use it, but keep in mind that it should be able to cause disinfection and reversal of the pH, and then you should follow up all the patients and motivationally engage them from the journey. So what pediatric dentists are good at is that they can really empathize with the patient, and that motivational engagement actually turns up in the patient coming back to you. So they will come back to you even after 5 years from trauma, or maybe 10 years from trauma if you are working in a private practice, and then you will be able to appreciate the results of your regeneration, and you will be doing a change to their lives. And that's the beauty of the regenerative approach in the non-vital traumatized teeth. So, and that's what we were discussing today. So with this, I would end my presentation, and I would like to invite you to a couple of meetings. One is the IAPD virtual conference, and as a pediatric dentist, you can participate in that, and it is going to be a good scientific extravaganza in June 2013. That's a virtual one. And that's Indian Society of Dental Traumatology conference. That's a bio bubble conference, which we will be opening up registration pretty soon, and that's in a western state of India, which is Goa. So that's near sea beach. So if everything goes well, and God is kind enough, and we are back to our traveling. So you can come and you can enjoy some Indian hospitality, and you can be part of this magnificent conference. And before I take a leave, so this is the department which I work in. That's our head of department, Professor Vijay Prakash Mathur, Dr. Kalpana Bansal, Dr. Rahul, all the senior residents and the postgraduates of this department. They work very hard for the patients which come to us. And with this, shukran, thank you very much for your kind listening, and I will be happy to answer the questions. Thank you very much.
Thank you so much, Dr. Tewari, for this informative lecture. It was really interesting seeing all the clinical success you did for the management of these cases, improving the prognosis, which I think from my side, it will definitely affect the quality of life of these young patients. You got many thank you messages and positive feedback from the audience regarding the lecture, and I think we have a lot of questions. I will select from them due to the time. One of the audience asked, what is the difference, what do you prefer between calcium hydroxide and triple antibiotic paste?
Okay, so that depends upon the case. So in my practice, I prefer calcium hydroxide because it serves double purpose. I am trying to improve on increasing the pH. So in the lesion which is quite acidic, if I push in calcium hydroxide, it is trying to disinfect and it is trying to increase the pH. And in one of the systematic reviews which my colleague Dr. Rahul did, so in that systematic review, we also found out that in cases where we are doing revascularization, the least cytotoxic effect on the stem cells of apical papilla has been documented with calcium hydroxide. So that's still unpublished, but then we prefer calcium hydroxide. However, in the cases where there is a closed apex and there is not a significant periapical lesion, so in these cases we can actually use triple antibiotic paste because that's also quite good.
Thank you so much. One of the audience said, can you please share with us the guideline you are following for taking X-ray for trauma patients?
Okay, so the guideline which we have is same as we have for International Association of Dental Traumatology guideline. Usually it depends upon the type of injury we have, because the question is about trauma cases. So I'm just talking to you about in general about dental trauma. So in the cases where we have crown fractures, we usually take just one radiograph. And in cases where we suspect a root fracture or a crown root fracture, we have at least 2 angulations for a radiograph. In all the radiographs, we always try to do using our guides, the radiographic guides, and then if you RVG positioners. So if you have RVG positioners, then side by side all your radiographs will be from the same angulation. So that's quite important for us.
Thank you so much. One is asking, what is the criteria for poor prognosis tooth from your opinion?
Okay. So nothing is poor prognosis unless and until we find that there is, unless and until we can see it histologically or we can see after extraction. So poor prognosis sometimes is dependent upon the delay. It is dependent upon the treatment which had been done before. Sometimes patient comes to us for retreatment and we find an instrument is broken inside, a file is broken inside. Then that's definitely a poor prognosis or a difficult case. There can be some cervical resorption or a resorption which needs to be sealed. So if there is an endodontic complication, so it definitely reduces the chance of tooth to survive. But the age which we are dealing with, especially as a pediatric dentist dealing with dental trauma, that's the age from 7 years till 14 years usually. So if the age we are dealing with, that has very less of prosthodontic options. So in an adult patient with poor prognosis tooth, you can extract and put in the implant, but for us it's not an option. So as long as it is possible for you to work with the tooth to make it survive for a longer, so that the bone is forming well, so that's what you should be doing. So try to save as long as possible, all cases, whether it's poor prognosis or a good prognosis.
I have a lot of questions, but the last one, after keeping calcium hydroxide, external resorption starts. What are the options left for saving the traumatized young permanent tooth?
Okay, so calcium hydroxide usually does not lead to external root resorption. So it actually reverses external root resorption, and that has been proven in scientific literature. So in the cases where you find that the external root resorption has taken place, it is related to your delay or the patient's delay in reporting to you, or our delay in removing the pulp out of it. So if you can remove, in all the cases of luxation injuries where the injury has been to periodontium, if we are able to remove the pulp within 14 days or 10 to 14 days, and in the cases where the root apex is mature, so always ensure that the pulp is removed in those cases. Follow the guidelines of International Association of Dental Traumatology, and try to look into that literature, that guideline, every time a case comes to you. So that will help you in improving your understanding of dental trauma pathophysiology, and that's quite important. And calcium hydroxide doesn't actually cause resorption, it reduces it.
Thank you so much. It's really amazing and interesting
Thank you.
listening to your presentation. On the behalf of the SSPD, I would like to express my great thanks for Dr. Nitesh Tewari for
Pleasure.
accepting our invitation and from giving us from your time to give this wonderful lecture. And and I really wish that we will see you, inshallah, in future webinar talking about special care dentistry and stem cell research.
Thank you very much.
Uh,
I will be happy to respond to any of the questions or the comments on my email, or any of the social media. If anybody wants to connect, I will be happy to share my experience with you. Thank you so much.
Thank you so much, Dr. Tewari. As you can see in the screen, this is the social media accounts and the email for Dr. Tewari. If you have any questions, you want to contact him. Thank you so much, Dr. Tewari. Now we will have another flight from your place again to Lebanon to Beirut. We will meet Prof. Nada Chedid. Prof. Nada is a professor in the Department of Pediatric and Community Dentistry in St. Joseph University. She's a clinical associate in orthodontic and dentofacial orthopedic division in the American University of Beirut Medical Center. She is former chairperson and co-director of Pediatric Dentistry Master Program in Department of Pediatric and Community Dentistry in St. Joseph University in Lebanon. Prof. Nada. Prof. Nada, can you hear me? Okay. Walaikum salam. Prof. Nada, can you please hear me? I can see you. I think I have a problem in the sound. So we solve that problem. I'm really sorry for this problem in sound. Dr. Nitesh? Prof. Nada?
Prof. Nada, can you please check the audio from the top menu? Make sure it says use mic and speakers.
Yes.
Prof. Nada, can you hear me?
Yes. Yes,
welcome.
I can. Thank you. I hope you can hear me.
Yes, you are. Yeah, it's really clear. Thank you so much for accepting our invitation, Prof. Nada, to be with us tonight. It's really an honor to have you.
It's my pleasure. It's my pleasure. Let me just try to find my presentation. Well, here we go. Here we go. I don't know if I'm visible on camera anymore. I'm not sure. Can you see me? Hello? Can you still hear me?
Yes, Prof. Nada. I can hear you.
All right. Can you see me? Because I'm not sure. Okay. All right. All right. Thank you. I'm sorry about this. Yes, go ahead, please.
We are really pleased to have you, Prof. Nada.
Thank you. It's really my pleasure.
So, Prof. Nada, today we'll talk about oral health management for pediatric cancer patients. As you know, in the 15th February, the world celebrates the International Childhood Cancer Day. We all agreed that oral health care plays an integral part of cancer management. Prof. Nada, in her presentation tonight, will address for us the oral health aspects of cancer, dental cancer patients, and she will review with us the preventive and curative aspects of dental care. She will offer for us a protocol for dental therapy along each step of oncology management. Dr. Prof. Nada, you can share your screen now, please.
Okay. Can you see it?
Yes, it's clear.
Okay, so let's get started. Okay, I hope you can see the full screen now. Okay. Okay, just a second. Okay. The problem is I cannot see my screen. Okay, there we go. I'm sorry about that. I'm not very tech oriented. I would really like to thank the society, the Saudi Society of Pediatric Dentistry for hosting me and for hosting this webinar. I was really very interested to hear my predecessor, and it's going to be a very hard task to measure up to the excellent lecture I just listened to. What I'm trying to share today with you is something that we may come across at any time during our work as pediatric dentists. But before that, I would like to show you our dental school in Lebanon, here in Beirut. This is St. Joseph's University Dental School, and we just turned 100 a few months ago in September, the exact same day as Lebanon turned 100, actually. So this is our school. This is our research lab. We have a biomaterials unit, oral biology, oral health, and craniofacial anomalies unit. This is a new campus, as you can see. So why do we need to talk about pediatric oncology patients specifically? Why is their oral health management different from other children? Well, because the oncology treatment is going to carry with it complications. And if we do not look at the oral health, we're going to decrease the outcomes. Whereas when we do look at this oral health, we will increase outcomes and diminish complications. What do we do? What we do is preventive, curative, and palliative care. And it depends on which stage of the treatment we will see the patient. How do we do it? We'll do it with a healthcare team, meaning we're not alone in this boat, and following scientific guidelines and per the individual patient's needs. When do we manage this oral health in the pediatric oncology patient? Basically at every step of the way, during, before, during, and after cancer treatment. And cancer treatment can be either one or a combination of these three options: chemotherapy, radiation therapy, and bone marrow transplantation, which is also called hematopoietic cell transplant. So without going into too many numbers, what we know today about pediatric cancer is that the survival rates have so much improved that it's not at all like it used to be maybe 20, 30 years ago. Today, a child who's diagnosed with cancer has about 90% chance of survival, which is an excellent number, which means that any one of us is someday or another going to meet one of those patients in our practice, be it in a hospital or in private practice, which means that we, of course, need to know how to handle these situations. A little reminder here about the phases of oncologic treatment, and this goes for ALL, which is the acute lymphoblastic leukemia, which is the most common type of cancer in children. Even though we have those excellent survival rates, you need to know that cancer deaths are still the second most important cause of death in kids below the age of 14. So we need to be a little bit familiar of these oncologic treatment phases. We're not going to be the ones to administer them, but we will be accompanying those kids along this journey. So the first phase is the remission induction, which is a phase of aggressive treatment. And then we have the phase of the central nervous system prophylaxis, which is also called the preventive phase, then the consolidation phase and the maintenance phase. Those phases are of different length. The first one is about a little bit less than a month, and it means it needs 3 to 4 drugs that are administered intensively. And in the second phase, there's cranial irradiation or another chemotherapeutic agent injection. Then the consolidation phase is an intensified treatment to minimize drug cross resistance. And then the maintenance phase is the longest one, which is every 3 weeks approximately a treatment, a round of chemotherapy. These phases, each one of them has a different reason for being here. It's a protocol that has been studied for a long time, and it's the best that science has to offer now. Along each one of these phases, we can have a different type of problem with the child who has cancer. So I will try, and I'm saying try, to have an overview of what we can do or what we can expect to see during these phases. Another important point here is that during chemotherapy, blood counts will start to diminish about 5 to 7 days after the start of the treatment cycle, and they will stay low for 14 to 21 days. They will go up again for a few days, and then the next cycle will begin, especially in the maintenance part, and then they will drop again, which means that we have a child that might have problems without any immunity to fight the infections. And this is where the challenge lies when these kids come to us. So what's our oral healthcare rationale? Why do we think that it's important that oral health is an integral part of cancer treatment? Well, first of all, because the mouth, as we know, is a source of many types of infections, because there are many types of microorganisms that have made their home in our mouth, especially kids' mouth, where they do not have the right oral hygiene, the appropriate movements yet. And then, because the mouth is also very receptive to any type of chemotherapy or radiation therapy treatment that will be given to the patient. So it's like a two-way street, and we need to work with both sides of this street to achieve a good health for the patient and good outcomes. The key to success, however, is the patient
Prof. Nida? I just want to apologize for this internet problem.
I had connection about that.
Yeah, no problem, Prof. Nida. No problem.
We count patients' compliance if we do not explain why this compliance is important. So it's our job to do that, and to the parents, of course, because many times the patients do not receive oral care before the therapy starts, before the cancer therapy starts. And then they will have this immunosuppression because of the cancer treatment, and the oral health problem will begin to appear. And it's our work, our job, to educate them about the possible acute side effects and long-term consequences on the oral cavity of these occurrences. So, okay, what's happening? Okay, so let's see our first scenario. We have three general scenarios where the child presents either to see us either before the treatment or during the treatment or after the treatment. The best case scenario, of course, is if the child presents pre-treatment and if we have time to treat the child, because ideally the oral health examination and the dental treatment should occur about a month before the cancer treatment. However, very often the child cannot wait to start cancer treatment. So what we need to do at the initial evaluation is to review the medical history detailed. Of course, we do that with every child, but here we have to do it with much more detail. We have to ask about the type of cancer. We have to ask about the type of treatment for the cancer, the history of the cancer, and we have to look at the oral health also with respect to the cancer and what we are going to be able to do in the time that's left between the time that the child comes to see us and the time when the treatment, the oncology treatment will begin. And we do have to share this information that we collect and ask for information about the planned management from the oncology team and give them our planned dental treatment so that we can optimize and have the best plan for the treatment of the child. So when we're doing this initial evaluation, it's not just examine the child and decide on a treatment plan. We have to look at things a little bit differently. We have to identify the sites of oral or potential oral infections where we have to begin our management. So places where if left untreated, they're going to be irritating to the patient, or they're going to develop infections or some form of pain. All of this will have to take into consideration. For instance, a loose primary tooth or a loose crown from a previous dental treatment, and now we have this tooth that's exfoliating. If we leave it, it's going to injure the gum, and in the case of immunosuppression, this can be a little bit bothersome for the child. We might have some fractured surfaces. We might have some appliances. In the case of appliances, they can remain in the mouth as long as the patient can maintain a good oral hygiene and as long as the patient has not developed oral lesions that can make it very difficult for them to stand those appliances. So mostly we recommend to remove the appliances so that the patient does not have to worry about them. Any type of space maintainer that is not very, very well fitting or that is not very easy to clean, we might need to remove, even though it might cause some spacing problems. Also, if we have lesions such as an MIH lesion, such as the one that you can see in this picture, these are things that we need to take into consideration. And then we're going to look at other exams, such as the X-rays, and we're going to establish our priorities. So what is more important? If I don't have that much time, if I cannot see the child for more than one time, or where do I start? And if I look at this, the recommendation, all the societies, scientific societies and evidence-based recommendations say you have to start with the acute treatment and defer, temporize the non-acute treatment. So if I look at this, what's acute, what's non-acute, what can I do? What needs to be done actually? Many things need to be done in this particular case. We have teeth that are already very, very carious with very deep caries. We have some teeth that are exfoliating, they could bother the patient. We also have something that might be erupting during treatment, and that could also cause pericoronitis or some such problem. So all of this has to be taken into account. And then we prioritize. We prioritize in the following way. Anything that might lead to an oral health complication, an oral health related complication during the oncology treatment has to be dealt with first, such as infections, extractions, periodontal care, and any source of tissue irritation, which means that if I'm extracting a tooth, I have to be very careful not to remove any spikes in the bone or any granulomatic tissue or anything that could be irritating or could not heal well once I'm done. This management, this part, this priority one, has to be managed radically, which means if I see a deep carious lesion on a primary molar, I'm not going to try and go for a pulpotomy or pulpectomy treatment, because those treatments are not considered as definitive treatments in the primary teeth. And in the case of immunosuppression, they could lead to a very serious problem for the child. So these teeth are better extracted. However, if the patient has already had treatments such as pulpotomies or other, and the tooth is asymptomatic and the gums are healthy, we leave them be. We do not touch them. We leave them be and we monitor them. At the first sign of problem, then we'll do what needs to be done. Then we have our second priority, which is any carious lesion. And here we'll decide the order of with which we're going to start, depending on the pain or the pulp infection risk. And then we have the permanent teeth root canal therapy, and we'll see about that in a little time, and the defective restorations replacement. This is our second priority, and the management of these issues is the conventional way, the regular way. We restore. For the endodontic care, we have these guidelines that say if I have a reversible pulpitis, I will just do caries control. If there's an irreversible pulpitis, we'll do the initial canals prep and temporary double closure. However, if we have a necrotic pulp, if the pathosis is chronic, we only do endo if we have at least 7 days between the completion of endo treatment and the start of the myelosuppression, meaning the start of the fall of the blood count. Otherwise, we risk a very serious infection, and we wouldn't even know it's happening because there won't be any protective factors in the child. And if the pulp is necrotic with an acute infection, then we'll decide on endo or extraction by looking at other factors such as the patient's general systemic health status and the chemotherapy schedule. If it's very close, if we can fit this treatment in a period where the patient will be covered by his immune or her immune system, then we're fine. Otherwise, we might consider the extraction. We have to think here a little bit differently than we usually think. We're not thinking of saving the tooth. Our priority is to save the child. The third priority will be for incipient and small carious lesions, which will be temporarily treated with fluoride products, with silver-diamine fluorides, with sealants, which can be later on replaced once the patient is in a better immunologic state. And then on sound retentive surfaces, we can preventively treat them with sealants so that we avoid having cavities develop in those places. Once this evaluation is done, once we know what we're up against as far as dental treatment goes, we have to select the modality. How are we going to provide this treatment? Some children are either old enough or just cooperative enough or have little work to be done so that we can treat them, regularly at the dental office. Some others will need something else. This is a kid who just fell asleep in the chair. She was just, a little doll. She fell asleep, so there was no problem treating her. However, other children will require maybe sedation or maybe even general anesthesia. And also, it's not only the behavior of the child that will lead us to go to general anesthesia. Sometimes we need to do a very efficient, very quick, and very comprehensive treatment, and we don't have the time to do it except if we go into the OR and do it in just one time. And this is what we do when we need to do it. During this initial evaluation, it's very important to discuss with the parents and the child, and discuss with them and educate them about the oral and dietary hygiene that is necessary during this trying time. And as I said earlier, it's not their first priority, but it's our duty to explain to them that it is a priority. So yes, they will have to brush. I'll tell you something. At one of the places where I was lucky enough to work, a hospital that treats cancer children, the staff would advise the children not to brush their teeth because they were afraid that the gums would bleed. Of course, the gums would bleed because the children were not brushing their teeth. And there will come a time during treatment when the brushing or the flossing will be painful for the child. So at that time, we can, alleviate some of it. We can do a little less. We can use a wet sponge. We can use a sponge brush, but the cleaning has to be done because it's one of the keys to keeping the mouth infection free. So it's important. Very soft toothbrush, some fluoride toothpaste, as long as the patient can stand it, as long as they don't have lesions in the mouth that can prevent them from that. So again, with our first scenario where the child presents pre-treatment, if my treatment, my patient's treatment is chemotherapy, and the child presents with this type of dental needs, this is a very young child, 4 years old, and we already have some early childhood caries lesions, some of them deeper than others. What I have to consider here again is, can I leave those teeth? The only way I can leave a tooth in a patient's mouth is if it does not need endodontic treatment when we're talking about primary teeth. So I will have to carefully assess the radiographs, the clinical aspect, and the history. Has the child ever complained of pain? For instance, in this particular tooth that worries me a little, the lower left second molar, this is the big issue here, and the upper right central. These are two teeth would probably maybe this one we can manage, but maybe not. And if not, when I extract it, I know I'm going to be up against a kind of problem because I cannot maintain the space. Of course, I'm not going to put a distal shoe in here with a child going through chemotherapy and radiation therapy. So there will be other problems later. But again, my priority now is that the child can go through this treatment that will save their lives in the best possible way. And the dental needs are important, but they are not the first in line. If, again, a child presents pre-treatment and the treatment will include radiation therapy. By the way, usually it's rare that we have radiation therapy without the chemotherapy, but it does happen sometimes for some types of tumors. The radiation therapy will introduce a new factor for me. It's the fact that there will be long-term sequelae, whereas the chemotherapy does have some long-term sequelae, but not as many as the radiation therapy, because we're talking about a child with many structures that are still evolving, still being built, actually, like our tooth buds here, and they will be affected because radiation therapy is almost always directed to the head and neck. Because of the question of the blood-brain barrier that the chemo agents cannot cross. This is why we need the radiation therapy to go and get those possible tumor cells that are hiding in the brain. And this is a problem because all these areas are a work in progress. We have bone that is growing, we have tooth buds that are evolving, and their development will stop, or it will be affected one way or the other. We will have teeth that will erupt with shorter roots, with malformed crowns. Sometimes if the radiation therapy and also the chemo, but essentially the radiation therapy, if it starts early enough, it will kill the cells that might have given, for instance, here we have an alveolar that will be later on an 8, a wisdom tooth. It might not develop. So all this has also to be kept in mind when we plan the treatment. Not just that I need to remove the cavities so that the child, or the carious teeth, so that the child will have a better prognosis, but also what will I do once their life is not in danger anymore. I have to plan for later on for orthodontic, maybe. Can we do orthodontics? It's another question, because also when you have had irradiation to the head and neck, it becomes a question mark. When can we do ortho? What type of ortho can we do? And is it really going to benefit the patient to do the ortho in such conditions? So these are questions that need to be addressed also with the parents and the children early on. Another third group in this scenario where the child comes before the treatment is the child that has to have a hematopoietic cell transplant. And in this particular case, we had a child who was referred for assessment before checkup and planning for treatment before they will go to their transplant. And the oral exam showed not too many cavities, incipient caries with preventive restorations, but we needed also an X-ray to rule out other caries. So this is the first visit. This is the note that I sent back to the oncologist, and this is the dental progress notes. And after the panoramic X-ray, we decided that we found out that there was nothing much. We did this in just one time, and the child was free and ready to go for their life-saving treatment. In other cases, we might have this type of children that come before their cell transplant, and this is a completely different approach because we have a completely different problem. We have look at the X-ray, we have some teeth that are missing or near missing. We just have some roots. We have some that have had pulpotomies, but here we can see that there is internal resorption. We have this that has a very deep carious lesion. It's a different approach. And here again, as I said, this is a patient that will be irradiated differently and that will have a chemotherapy in a different protocol. The chemotherapy will be given in just one time, not just one day, but on a very close time, and the child will be absolutely without any immune defense for a while. So we have to be very careful about what we leave in their mouth. We cannot leave anything that could possibly lead to life-threatening infection. So this is where we are very radical in our treatment choices. In the HST, there are also treatment phases, and those are 4 phases. The first one is the preconditioning, and the second is the conditioning neutropenic phase, where the patient receives all the chemo in about a few days, plus a total body irradiation, and then they're completely defenseless. And then the third phase is when we begin this complete neutropenia and the transplant is done, and we wait until the recovery and when the immune system kicks in again. And the final phase is the immune reconstitution and recovery from the systemic toxicity. So we have an immunosuppression period that precedes the HCT and a prolonged immunosuppression that will follow this transplant. The total chemotherapy and body irradiation is done on a very short, in a very short time, which means it's going to be very radical, and we cannot do any elective dental treatment until the patient recovers their immunological capabilities. And this cannot happen before at least 100 days after the transplant. However, if there are complications such as the graft versus host disease or other complications, this might be an even longer time. So we have to be, again, very aggressive in our treatment. These are the patients that will go to general anesthesia to have all their treatments done before they go into their chemo and radiation therapy. We have to do it all in one time if we can manage it. We come to our second type of scenario where the child is coming to us during the treatment. These are children either who did not have the opportunity to see a dentist because their family or they did not have access to dental care for any type of reasons. It could be economic, it could be because they didn't know it was important in regards of the cancer treatment. So they will go into their oncologic treatment, and at some point when their immune status is not so good and they have forgotten to brush their teeth and they are eating so many karyogenic foods, because at some point in their treatments, these children have no appetite. And their doctors, their nurses, and their parents will urge them to eat anything, any sugar, anything, but they need to eat. So as you can understand it, dietary health and oral health are not optimal, way not optimal. So they come back with an emergency. Usually it's an emergency. They could come back for something that's not an emergency, but let's see. If it's an emergency, you will probably see something like this, which we don't see so much anymore in healthy patients. It's very rare to see cellulitis in healthy patients nowadays. It does happen every once in a while, but people are usually, aware of what's happening, and they do go to the dentist before they get to this stage. However, if we have this type of situation in a cancer patient, this is very dangerous, particularly when the swelling gets close to the eye. It can be life-threatening to the patient. So this is something that we have to manage, of course, in cooperation with the oncology team, sometimes and very often with intravenous antibiotics before we can even touch the tooth, and also taking into account the blood counts. And because again, in a case like this, a tooth that has caused such an infection will have to be removed, which means it has to be extracted, which means there's a potential for bleeding, which means I need to have some conditions so that this bleeding will be properly healed. So these acute odontogenic infections will sometimes necessitate transfusions because they cannot wait to be treated, and the patient's blood counts are very low. And of course, it's not my decision as a dentist. It's something that is decided with the oncology team. Well, there are guidelines, and we saw them earlier, or I'm not sure if we saw them already in the table. There are guidelines. We can absolutely not extract if the platelets count is below 40,000, or if the absolute neutrophil count is less than 2,000. Maybe sometimes between 1,000 and 2,000 with the oncology team approval and with some precautions, it could be done if there is a real emergency. So other types of complications are related either to the oral health of the patient or to the condition. And among them, we have the periodontal problems. Heavy periodontal bleeding is one of the signs of leukemia when it's at its onset, and rapidly progressing gingivitis and gingival pathology is also something that happens in these patients, especially once they have started their treatments, which can also lead to some xerostomia and other types of lesions in the mouth. Periopathologies are also very much very heightened, very much more dramatic in those kids. We see necrotic spots. We see rapidly progressing periodontitis lesions, and again, the oral hygiene of the patient doesn't help. So this again is where we have to deal with the medical periodontal problem, and also with the at-home problem of trying to maintain good oral hygiene in very difficult, painful conditions. Again, we have to speak many times with the parents and the children to remind them of the importance of this thing. Otherwise, we might keep seeing those types of lesions we just saw before. Also, we may have different types of soft tissue lesions, either because something has been bothering the patient, injuring the patient, or because we have some form of candidiasis or aphthous lesions, or any type of soft tissue lesions that can degenerate and be much more painful than it would be in a child who does not have immunosuppression. This can lead to the child not eating well, not eating properly. Oh, here we are. So our considerations before dental treatment, if we need to do radical treatment during oncologic therapy, is to look at the absolute neutrophil count and at the platelet count. the absolute neutrophil count has to be above 2,000, and the platelets would preferably be above 75,000. However, if we are in those two areas, for instance, above 2,000, we don't need antibiotic prophylaxis if the ANC is above 2,000. If it's between 1,000 and 2,000, it's preferable not to treat. However, if the procedure is not too invasive and the patient's health status allows it and will benefit from it, then we'll see with the oncology team about antibiotic coverage, which can be done per the AHA's recommendations for SBE. But if there's an infection that we can see or it's unclear, then we definitely will have to do more than prophylactic antibiotic coverage. Maybe for a week, we'll give a prescription. If, however, our ANC is below 1,000, then we will defer care unless there's an absolute emergency, and then it's probably better to hospitalize the patient to perform the treatment under medical supervision with the medical team, and of course with a longer period of antibiotic coverage. This goes as well for the platelet counts. We might need to transfuse the patient when the platelet count is between 40,000 and 75,000, depending on the procedure and on the patient's general health status. However, we can also sometimes just use localized procedures to manage the bleeding, such as sutures or pressure packs or things like that. Otherwise, below 40,000, it's preferable to defer, except in emergencies. And there, again, we'll have to see with the physicians, the team, and add more procedures than just the blood transfusion. So if this kid that comes to see us during his treatment or her treatment is in kind of a hurry, in an emergency situation, and they are in the maintenance phase of their chemotherapy, meaning they are in the last 2 years of chemo, then what we need to do is to program our treatment during the times when the blood counts are high, except if there's an emergency, which was the case in this case here. The initial visit was an emergency with an infection, and there were deep caries in the lower molars. The patient, when we saw her, was taking Augmentin, was taking antibiotics. We spoke to the physician and he said, go ahead, she can have the extraction today. And this is what we did. Now she needed more extractions, and for those, we programmed them according to the chemotherapy program. So do we always need antibiotic prophylaxis? It depends. There is no evidence to support in every time the use of antibiotic prophylaxis if the patient has an indwelling catheter, which is a port inserted in the patient so that they don't have to get pierced by a needle every time they need their chemotherapy. So some people prefer to give antibiotic coverage, some others prefer not to, but there are no studies really going one way or the other. If we are going to give this prophylaxis, it can go with in accordance with the AHA standard regimen for the endocarditis prevention. So that was the first case I spoke with you about, is when there was an emergency during the chemotherapy. However, sometimes the child will have started some dental treatment before chemo and wants to continue dental treatment once the chemo has started. And again, here we will look at what happens with this child from the blood standpoint. This is a kid who was seen at the first time he was seen was like almost a year before we saw him the second time. In the meantime, he was having the cancer treatment. At the beginning, there were some cavities, but when he came back, some cavities had turned into very loose teeth. So the treatment plan changes during those months, and we have to reassess. We do not go and use the same treatment plan that was made a while ago. We have to look again at the patient as if this were his first visit. And then we see the notes, schedule the dental appointments when immune status is good. And the last appointment had to be cancelled. The last appointment on the sheet had to be cancelled because the immune status of the patient was not good at that time, which means that how do we know how the immune status is? It's because we ask for a blood test at the closest time possible to the appointment. And this means that It cannot be older than 24 hours far from the procedure. So this is how we know if we can treat the patient or not, of course, with the blessing of the oncology team. Again, during this type of treatment, the patient has to be monitored more closely than a regular child who does not have those problems. Another case of routine care during chemotherapy with a patient in the maintenance phase. This was a kid who needed extractions. Now, the first time she was seen by a general dentist. And if you look at the treatment plan sheet, you will see that some teeth were planned for pulpotomy and composite, or pulpotomy and crown. But when the pediatric dentist saw the case, and then the general dentist referred the patient to the pediatric dentist in the team, and the pediatric dentist said, no, I prefer to extract because we don't want, we do not want problems. And this is what happened. As you can see here, the patient will continue dental work with the pediatric dentist, and the pediatric dentist continued with a more radical treatment plan. The permanent teeth, the permanent molars were erupted and they received sealants. One of them had one tooth needed composite, compomers, sealants. Anything that can be done that is not very invasive, we do. But anything that needs invasive invasion of the pulp, it's preferable to extract. Also, these are the blood tests that we get every time that the patient comes. We need to make sure that we have a bleeding time that that is good enough for extractions or for injections of anesthesia, because we don't want to have any hematoma or intramuscular bleeding later on. So this is very important. Now, for the surgery meaning any extraction and curettage or whatever during chemotherapy, we have some guidelines which include that we would like to have primary wound closure, so we could suture if needed. We have to make sure that our extraction is very far away from the next time that the patient's blood count, absolute neutrophil count, will fall below the 500 millimeter critical point, 500 per cubic millimeter. Now, some authors do not like to use intraalveolar hemostatic packing agents because they worry that the hemostatic this is too much hemostasis and it might lead to necrosis of some tissues. Some others say no, we can use them. However, a good option is to use tranexamic acid, which is an anti-fibrinolytic agent, which will help with prolonged life of the blood clot. Again, if we have low granulocyte counts, A and C counts, we give antibiotic coverage. And if we have platelets below 40,000, we do transfuse. Among our oral complications for chemotherapy, there's a neurotoxicity. And this is pain that the patient will feel, very painful, whereas the teeth have no problem. And this is because of some of the drugs that are used during the prophylaxis phase, specifically vincristine. And when we know that the patient is taking the drug, we know how to reassure the patients. It's unfortunate, but it will pass. Another complication is the enamel erosion due to vomiting and nausea. And this, fortunately, is a problem that we see much less often nowadays with the agents that are used nowadays. Still, some patients can need to rinse the mouth with a mix of baking soda and warm water and some salt to help reestablish the mouth pH after episodes of vomiting. If the child presents during radiation therapy treatment, our main concern is going to be the rampant caries that we see. These are there will be less saliva, so the caries process will be accelerated and much more devastating. So this is something that has to be aggressively treated with fluoride varnishes and crowns, if we can place crowns. It depends on where in the radiation therapy the child is now. One of the oral complications of radiation therapy that is very much talked about is osteoradionecrosis. This is not very often seen in children. However, the risk persists throughout life because the radiation will will lead to damages of the lining of the vascular system of the bone. And this will mean that we'll have vasculitis, ischemia, and risk of bone fracture, diminishing of the blood flow, diminishing of the nutrients and the defense cells, which will reduce the collagen formation and the wound healing capacity. And this is a serious problem because this will cause bone ischemia, especially if there's a trauma. And what is a trauma? For instance, an extraction, a tooth extraction is a trauma. So this is something we have to keep in mind when we plan treatments for patients who have been on radiation therapy or who will be on radiation therapy. It has to be taken into account. And there are some things that we can do to prevent these problems, minimize the infection, minimize the hypovascularity. This is where we do not want to use vasoconstrictors, and minimize the trauma, meaning if we can keep a permanent tooth by endo instead of removing it, that would be better. So these are some guidelines that you can have. Another problem is trismus, a reduced mouth opening on the side usually of the radiation therapy, and this is prevented by giving the patient exercises to start as soon as the radiation therapy begins and to continue for a long time after it stops, because otherwise the muscles will be very stiff and it will be very difficult for the patient to re-establish a proper mouth opening path. If a patient comes to you with while they are in the prophylaxis phase, which means they are taking the chemo and the radiation therapy at the same time, this is a very important time to be communicating with the team to know, because this child needed extractions. As you can see, there's the beginning of the healing after the extraction here, and this part has healed a little bit better. And of course, we were worried about osteoradionecrosis, among other things. But the physician reassured us that the spot where the radiation therapy was being targeted was not close to the jaws, and that we could proceed with the extractions without fear. And this is what was done with, I remember, if I remember correctly, there was antibiotic coverage at the time. So radiation and chemotherapy have also immediate oral complications, not the least being mucositis. Any and many types of soft tissue infections, soft tissue lesions, also problems with the saliva and problems with tasting food. This will lead to difficulties in feeding, in hydration, in speech, in oral hygiene, which will also increase the risk for the oral and systemic infections, and will lead to a possible nutritional compromise, meaning weight loss, anorexia, dehydration, which leads us to ask, what would be the cancer prognosis if we do not take care of these things here, so that we do not have to come to these things here? So it's, again, one of the reasons why we need to be part of the team who takes care of those children. Oral mucositis is a very serious condition that begins with mucosal burning, dry mouth, discomfort, and pain. If it's not dealt with, it will lead to pain so intense that the child will refuse to eat or drink and will not be able to talk. So again, oral and systemic infections, nutritional compromise, anorexia, dehydration. The management of oral mucositis is usually to try to eat bland foods, avoid spicy foods, avoid things that need to be crunched, because the mucosa becomes very friable, very dry, and you have those burning, like little burns that will coalesce and sometimes become very, very big lesions. Baking soda can help. Bland rinsing with saline solution also can help. And also some pain medications help. There are also therapies. One of them is palifermin, which helps with rebuilding the keratocytes, but cannot be used if the cancer is of epithelial origin. And also some coating agents can help, because they will coat the mucosa and then the child can eat. Also low-level laser therapy helps with healing those lesions. Infection in radiation and chemotherapy comes from different reasons. Okay, you can see them maybe, but it also comes in different forms: fungal, viral, bacterial, and each one of those forms has to be dealt with depending on what it is. So we have to monitor closely for early diagnosis and treatment, because many times the signs, the classical signs that we're used to, will not be visible. They will be reduced during the neutropenia, and we won't be able to tell that the patient is having an acute infection. Plus, the clinical appearance may differ from what we are used to in an infection or a candidosis or herpetic infection. So anytime we can, we should biopsy or culture the suspicious lesions, try to find the right targeted medicine. And in the meantime, while we wait for the result of the culture, we can give prophylactic medications until we can give the specific therapy. The salivary gland dysfunction is one of the most important problems that oncologic treatment will entail, because it will lead to a saliva that is not protective of the teeth anymore. It's thickened. Sometimes it's even absent, not only reduced. And this will again increase what? Infection risk, caries risk, speaking, chewing, swallowing disabilities, and also affect the vital prognosis. If the child cannot eat, cannot chew, we're going again to face weight loss, anorexia, etc., nutritional compromise. So again, here what we can do is either try, okay, there are some medicines that can manage the xerostomia. We advise the child to sip little bits of water, rinse often with saline, use sugar-free gum or candy to promote salivary function, and in some situations use saliva substitutes. However, this is a problem that is long term. It's not going to go away once the treatment is over, because some of the salivary glands will have sustained some permanent damage. So it's important to keep those procedures that will help fight dry mouth for the long term also. The taste alterations, everything tastes bland, everything doesn't taste good, or sometimes it tastes bitter because of some of the medicines. It's a problem, because then the child will not want to eat anymore, and that's a problem, because we need them to keep their weight, we need them to keep their strength. So there are things that can be done to promote better nutrition. There are many guides for these things, and discussions with nutritionists are a very good idea in this type of situation. When the patient is undergoing HCT, actually the immunosuppression is so severe that we cannot do any dental treatment. Anything will have to be deferred. If there is something that's really urgent, then it has to be the transplant team's decision to let us or not let us do the treatment. It will be their decision, because here you have someone who has absolutely no defense. They will be living in a sort of a bubble, and there will be very difficult consequences if they catch an infection. Once the treatment is finished, the child can also come post-treatment to us. What do? We still have some precautions to think about. We still have to consider salivary function. We still have to consider how long has the chemotherapy been arrested. Are we sure we have the right blood counts? These are questions that need to be asked not only to the parents, but also to the physician. But once the patient is in remission, we can resume regular dental recall schedule when the treatment is finished and all side effects have resolved, including the immune side effects, meaning that the patient must have regained their complete immune potency so that we can treat them like any other regular patient. And this can be told to us by the oncology team or the treating physician. Radiation therapy, again, I said earlier that we'll have problems with osteonecrosis. Not too many in children yet, not too many reported in the literature. However, adult cancer patients do have this problem. We have other types of problem with radiation therapy with the kids. It's the dentofacial growth and development that is affected. So we have to monitor this very closely and try to avoid surgery on irradiated bone as much as we can. Now, some patients will have gone into chemotherapy wearing some types of appliance, maybe not these types of appliance necessarily, but some type of removable appliance. And during treatment, because of mucositis and oral lesions, they might have to let those appliances, put them aside. Once we finish treatment, we have to reassess. Can they use the appliances? Have their soft tissues healed enough? We have to follow up regularly on the appliances themselves and on the patient's health, dental health status. Also, we have to remind those kids that they need, for as long as they live, they will need to use fluoride on a regular basis because they have had this difficult time, and this difficult time has left marks on their oral health. If the child comes to us after finishing, like in this case, status post radiotherapy, status post chemotherapy for assessment, this is a child who was not treated while their oncology treatment was going on. They came afterwards, and they had some caries that looked either like early childhood caries or maybe rampant decay due to the radiation therapy. All the primary teeth were affected. All 20 teeth needed some form of treatment. So this was to be done after, of course, investigating more. And again, speaking to the oncologist to make sure that we could extract without risk, or that we could maybe perform some other kind of treatment. The orofacial development of the young child after radiotherapy and chemotherapy can be damaged. They can be damaged to the osteoblast, odontoblast, ameloblast, any type of cell that is developing at the time, which will lead to abnormal craniofacial growth and development of abnormal development of the teeth. Again, some will be completely arrested, and some tissues will be atrophiated. This is something that we need to keep in mind, to talk to the parents, the patient, and even the oncologist about. When we see the patient post HCT, if it's in the immediate post HCT, we cannot do any routine dental treatment. We just do the oral hygiene and emergency care, trying to be conservative as much as possible with the treatment, because the patient is still under immunosuppressive therapy, although it's not as aggressive as the one prior to the transplant. This therapy will be discontinued 2 years after the transplant. However, this type of transplant will have two particular types of problems: gingival overgrowth that is due to the cyclosporin, which is the low level anti-rejection drug, and this we find a lot in children. We find in about 10% of the adults, but in about more than 90% of the children. It is, however, reversible. So when the 2 years have passed and the cyclosporin treatment is stopped, this will go back to normal. Surgery is rarely needed. However, it's important to maintain oral hygiene so that this gingival overgrowth can be kept to as little of an overgrowth as possible. The most serious problem with the transplant is the graft versus host disease, which is a situation where the transplanted cells recognize the host tissues as foreign, and it occurs in about half the patients. It can be acute or chronic, and the manifestations will vary depending on the condition severity. I'm not going to go into all the details. There are many, many very well written articles on the subject. The management here is not up to us alone. It's a multidisciplinary management, because this can be a very debilitating disease. The treatment goal being to minimize the toxicity and the relapse. Yeah. Also, one of the most important problems of this is that it could lead to relapses in many parts of the health situation. So topical treatments are preferred. Bicarbonate again helps a lot, again with the oncology team. If 100 days post HCT have already passed and we see the patient with this problem, it's probably because of the conditioning's chronic toxicity. So we see less bacterial infections, but we see more of the graft versus host disease. It's okay to do periodic dental examinations in this period. However, we do not do invasive treatment because we have to look at the immune function impairment first. If the child comes after complete therapy completion of the therapy. What do we do now? The patient is in remission. We're done with the cancer treatment. Now we think that they will survive long term. The objectives of our treatment are, of course, to remind them to maintain an optimal oral health, to reinforce the importance of the lifelong optimal oral health care, and also to talk about and address the immunosuppression's long-term effects. And also, there's one thing we need to also always remember. These are kids that do not really like being at the dentist's because they have been through so much. They don't want another person poking into their bodies again. So management from the standpoint of behavior is an issue also. We need to bring them from here to here. It's our job and it's our mission. So it's an important part of what we do. To conclude this presentation, before, during, and after any cancer therapy, multidisciplinary team approach, it's a group effort. It takes a whole village, as they say, and we're part of this village. We hope to do our job properly so that this present crisis that the child is living will be passed very soon. We'll help them to look beyond it, to look to a brighter future, and help them make it possible. On this note, I thank you very much for hosting me today. And I invite you to come see us in Lebanon. For those of you who watch some TV, I come from this particular village. And if you watch a program that's called El Heibi, this is where it's shot, in my village. So if you ever come to Lebanon, please come and visit Hammana. It's my village. It's the real name of the place. Or you can just come to Beirut also. We're famous for our cherries. So please come by, come see me, and have some good cherries from Lebanon. Thank you very much.
Thank you, Prof. Nada, for this informative lecture. It was really interesting. Thank you so much.
I hope I have not overstepped my time. I'm not very good at keeping time sometimes.
Thank you so much. I think you covered the topic from all aspects. In Saudi Arabia, we have many medical institutions that provide medical and dental rehab for dental oncology patients, and I think the protocol you address will be an excellent source and reference for all pediatric dentists when they are going to treat dental oncology patients.
Thank you so much.
Let's have some questions, if you don't mind, please.
Of course.
Okay. One of the audience asked how many time period before chemotherapy or radiotherapy we should complete dental treatment for the child.
It's not really a question of time period. It's more a question of blood levels. So usually the treatment cycle is about 3 weeks, 21 days. The first week, if the child has just taken the oncology treatment, and I'm talking about chemotherapy mostly, at this point it's the best time to do the dental treatment because they still have their full immunity. After 5 to 7 days, these numbers will drop and they will stay low for between 2 to 3 weeks. When they come back up again, it's not enough before the other cycle begins. So it's best really just the same day, or the same day the patient is usually tired. The next day after the patient takes the chemo is probably the best time to do. I hope I have answered the question. I'm not sure if this was the question.
Thank you. We have another question. Around how much time period before radiotherapy extraction should be carried out safely?
Well, again, this depends on what area of the head was irradiated. And as I told you with the case that we saw, I was very worried about that. Was a case that we saw at the dental school, and the resident and I were both worried about extracting. So, because he was still undergoing the radiation therapy, it was not that he had finished. So we spoke to the oncologist, and he reassured us that the beam was not at all directed to the jaws. It was way up, and it was a low-level radiation therapy. So in that case, we could do the extractions, although the patient was still undergoing the radiation therapy. Again, here it becomes also a matter of what's more important. And it's always the medical treatment that will win, because the medical treatment is to save the patient's life. The only time when we can override or ride along the medical treatment is if the dental emergency can threaten the medical treatment's efficacy or the patient's health or life. So it's not up to me to decide. Usually it's a lifelong process of being attentive and taking precautions. Now there are now ways of protecting some areas with some drugs or some shields during radiation therapy, but it's still not very widespread. And again, it depends on what's being irradiated.
Thank you so much, Prof. Nada. On the behalf of the SSPD, we would like to express our great thanks for your time and for accepting our invitation. Inshallah, we hope that we see you, inshallah, soon in future activities. And we also hope that we can visit you in Lebanon as well.
You're most welcome. Thank you again.
This is the email of Prof. Nada if you want to contact her for any questions you want to have. Thank you so much, Prof. Nada.
Thank you again, and for your efforts in making this happen. It was a little bit difficult for me, but you made it so easy. Thank you very much. Thank you.
So at the end of this webinar, I would like to thank you all for attending this webinar. Thanks again for our speakers, Dr. Nitesh Tewari and Prof. Nada Chedid. Stay tuned for our announcement for March webinar. We are going to have great speakers and amazing topic. You can follow us on our social media applications, Twitter, Instagram. You can also visit our official webpage to be updated for any future activities that we're going to have. If you're not a member of SSPD, please join and be one of the member of the society and enjoy the benefits of the membership. Last but not least, I would like to thank the president of SSPD, scientific committee, and all the members of SSPD for their efforts to support this webinar. Thank you so much for attending this webinar tonight. Always remember, keep your scientific updated. You have all the tools to be scientifically updated. Thank you so much and good night. See you soon, inshallah.